about the Health Systems Board first? Okay. Maybe. Oh, okay. Okay, great. So, everybody, welcome. Today, so I'm Amanda Glassman. I'm from the Center for Global Development, but we're running this event on behalf of the Health Systems Board. Thanks to Lydia from Johns Hopkins for organizing everything and our panelists. And unfortunately, one of our panelists can't be with us today because he's had a death in his family, Ferdinando Regalia. Alex's dad died. So, yeah. So that's too bad. So I'm going to try and just give the broad messages of what he might have said today. But the real stars of the show are Omar Galaraga, who's from Brown University, a health economist with a lot of experience on cash transfers of various kinds. And then Carleigh, I'm kind of blanking on your last name, we just met, Krubiner, who is a bioethicist who works in who's a doctoral student, is that right? About to finish in the group that's led by Ruth Faden at Johns Hopkins School of Public Health on ethics. So today, our topic will be wide-ranging, but we'll be focusing on different kinds of conditional cash transfer programs and the ethical implications of the design and implementation of those conditions. Maybe I should pause. This is Sarah Bennett. Do you want to say something about the Health Systems Board in general before we go on?
Just very briefly, the DC Health Systems Board is an informal group of professionals spread across development banks, consulting firms, universities across Washington, D.C., and we meet once every couple of months. Mm-hmm. Sometimes it's a bit longer in between, and everyone is very welcome to come. And if you've got ideas about the nature of events you'd like to have, then please don't hesitate to contact me or Amanda and a bunch of us who organise it. Thank you. I'm sorry for coming in late.
Great, no problem. So first, maybe we should do a round of presentation, but could we just see a show of hands? Do you all already know all about conditional cash transfer programs? Okay. So I'm just going to say two words about them in general. One is that I think you could characterize them. There's one set of programs that we'll call broad conditional cash transfer programs. They're programs that were intended to be safety net programs, primarily to transfer cash to the poor, but they also had a secondary objective. I think it was a secondary objective, really, of human capital improvements through the conditioning of educational attendance or the use of some sorts of preventive healthcare services. And they started, I guess, in Brazil and Mexico, the big conditional cash transfer programs, and they cover up to 20% of the population. So these are very large, mainly government-funded programs with a safety net function, but that also, through their conditionality, have some effects directly via the conditions, but they might also have effects via the income transfer and via the education effect, nutrition. So that's a broad cash transfer program. And I think Carleigh's work focuses mainly on those kinds of broad, excellent, okay. So unfortunately, we actually won't talk too much about those broad programs then today, although I think some of your work could relate to thinking about conditions for those kinds of programs. And then there's not really a new program, but it's now being sort of talked about in the same literature, what we call narrow conditional cash transfer programs that are targeted to specific kinds of behavior change. So picking up an HIV test, or having a facility birth, or doing more exercise or stopping smoking. So they're specifically targeted financial transfers. And Omar will focus his talk on that. And I think they're pretty exciting. They kind of cover a lot of different fields all at once. You know, there's the behavioral economics part of it. There's the link to the conditional cash transfer literature. So there's actually a lot more in this space than initially meets the eye. Because when you talk to people who've worked in HIV AIDS a long time, sometimes they think, oh, it's some kind of new idea, some new thing. It's not actually that new. And I think with that, it's really good to just turn over to Omar because he has a very good slide about this very issue. So thanks.
Thank you so much, Amanda. My name is Omar Galaraga. I'm very happy to be here today. Thanks for the invitation. So I will talk specifically about conditional economic incentives for HIV prevention and treatment, but I was asked to take a step back and tell you a little bit about the history of this field. And it really starts with psychology, actually in the 1960s. So it's not new, this idea of getting rewarded for good behavior. So I found this article on brushing teeth in summer camp for children, 1969. So it's quite old. And you know, the idea of getting rewarded for positive behavior, of course, is even older. But in the psychology literature, it's called contingency management. And it has been very active since at least the 1960s. This is one article among very many. So last night, I typed contingency management in quotes in PubMed, and I got about 640 entries, you know, going back to the mid-60s. And that's just contingency management alone. So without adding financial incentives or conditional incentives, or the word that is preferred in the economics literature, which is conditional cash transfers. So contingency management is just the idea that we need to do something that is positive, and then we get rewarded for it. That's the basic idea from the psychology literature. It has been applied a lot in, to reduce the use of drugs and other harmful substances. And so that's why we have contingent on urine results. So basically being free of all these harmful substances. So most of the research in psychology about contingency management shows that it consistently works. So just to give you an example, it has been used most recently for smoking cessation. So there's very large trials showing that you pay people to stop smoking, they will stop smoking. And this is, you know, with cotinine saliva tests, so making sure that indeed I have not been smoking, then I'm rewarded. But it has worked for alcohol, heroin, cocaine, methamphetamines, etc. So it's been very successful in this area of substances. The main characteristics of these programs is that you have to have some very objective way of checking that indeed the behavior you want is being done. So in this case, it's a biological test. So some routine testing, robust routine testing, in this case of drug misuse, which is the most common application in psychology. You have to have some sort of targets which the service user agrees to. Of course, you know, I have to agree to stop smoking. I have to agree to have the tests on my saliva or my urine test, etc. Of course, you know, we will hear a lot more about the ethics of it, but of course it has to be voluntary. The incentives have to be provided in a timely and consistent manner. So a lot of the research shows that the closer in time that the incentive is given to the behavior, the better. We cannot always do that, but of course we can always try. There has to be the relationship, and the rules have to be very well understood by the user. So that's very important to have programs that are relatively simple, or at least that the users can really understand what's going on, so that they know the rules of the game, so that everything is transparent and everybody knows how to do the best for their own health. And that's the most important part, that I, as a user, feel that indeed this thing is helping me. This program is helping me to, in this case, have a healthy, drug-free lifestyle. So that's the idea. That is something that is going to help me be more helpful. So how have we moved forward from contingency management to HIV/AIDS prevention and treatment? So that's what the story that I'd like to tell you. So I started thinking about these issues when I was a student at Johns Hopkins almost 10 years ago. 2005, I started thinking about these ideas with other colleagues, with Steph Bertozzi, with Paul Gertler, and others that were thinking about this. How about moving these ideas into conditional economic incentives to stay free of curable STIs for people at high risk? That's what we started thinking about it, and I'll tell you where we are in terms of Mexico work. But a lot of work has been done to the effect, and now this global report of UNAIDS 2013 actually now recommends the use of cash transfers for HIV prevention for the first time. So this was very good news for us last year, and here's just a little quote. Cash transfers create incentives for safer behaviors and results from randomized controlled trials. So new strategies have emerged that reduce young people's vulnerability to HIV. So now this is officially in one of the tools in the UNAIDS toolbox. So that was very interesting to see. And I will show you why they've made this decision. I will show you a couple of the most influential papers that have come out in the last couple of years. But before going there, Ferdinando was supposed to talk about conditional cash transfers. So let me just make a parenthesis and tell you that from contingency management in the psychology literature, in the mid-90s, economists sort of discovered this idea and say, well, you know, our welfare programs, so our assistance programs for the poor, could be better targeted. So why don't we use some of these ideas? And Mexico was the pioneer. In 1997, they piloted a randomized controlled trial clustered. And in 1998, they launched this program then called Progresa, now called Oportunidades. And it was very well evaluated in terms of health utilization, and it has been replicated now in over 30 countries. So this particular book on conditional cash transfers from the World Bank is very interesting. It summarizes a lot of that literature. It's a very rich literature. Just on Oportunidades, I think there's over 200 papers right now in the literature. So if you want to know more about it, of course, take a look at this among other publications. So just, I don't want you to read that, but just to show you that there is very many papers in many countries. So Chile, Colombia, Ecuador. For example, in Ecuador, actually, this is Cristina Paxson, who's now the president of my university now. She's a health economist and has worked on this topic. But there's many other researchers that have worked on this with very rigorous methods. So regression, discontinuity design, propensity score matching, difference in differences, randomization, etc. So very well evaluated with very rigorous methods. Similarly, you know, a lot of Mexico papers, change in height, which as you know is very important, and change in age, height for age, etc. So in Mexico, Nicaragua, and other countries. Again, a lot of randomized controlled trials, a lot of people from the National Institute of Public Health, where I used to work before I moved to Brown University, and where I still have a lot of collaborators. So let me just summarize again, go back to the HIV literature, and now it's been growing as well. So this is a paper we published last year in Health Psychology, summarizing a lot of the literature on incentives for HIV prevention. So again, we found very many papers, and I will go into the most important ones, perhaps, are the Malawi papers and Tanzania papers. Again, I don't want you to read any of this, but you can see a lot of effects. So STI prevalence goes down, marriage rates go down, etc. If you're interested, please take a look at that paper to see the summary of this literature, which is getting bigger and bigger, actually, by the day. So this is perhaps one of the most influential papers in this literature, and it's a randomized controlled trial that happened in Malawi by Sarah Bird and colleagues. She was formerly here in George Washington, and Bert Gosler, formerly at the World Bank. So this was a large trial in Zomba district in Malawi, and it was incentives for young women to stay in high school. And the main result is this, that HIV prevalence is reduced. So the adjusted O's ratio is 0.36. So you can see a substantial reduction in the HIV prevalence among young women. And this is the conditionalities to stay in school. So this is the interesting thing, right? You're not conditioning directly on the outcome that you'd like, but this outcome is associated with the outcome of interest, which in this case is HIV prevalence. You can also see a positive outcome on HSV2, herpes simplex virus type 2, is also a reduction in the risk. Another interesting paper in this literature is by Damien DeWolk of the World Bank and Will Dow, Berkeley, and colleagues. Carol Medellin, who was at UCSF, and when this started some 8 years ago, And so this is in Tanzania. And here's a little different, because here the conditionality is to stay free of new curable STIs. So that's the difference here. And it's among heterosexual, older adults. So older with respect to the younger women, right? So it's the result here also is that they had low value and high value conditional cash transfer, and the high value is associated with reduction in the combined STI prevalence. So that was also a very important result. Initially was presented at the Vienna conference, UNAIDS 2010, and published 2013 last year officially. So these are the two papers that basically UNAIDS report last year is picking up and saying, well, there is now evidence that perhaps cash transfers for HIV-specific behaviors seem to be useful. So let me tell you a little bit about our work in Mexico. So as I told you, we started thinking about this in 2006. We wrote a proposal to the NIH, and I was then working at the National School of Public Health in Mexico, and we started thinking the first step, well, would the target population be interested in this approach? And so the first thing we did was a willingness to accept the study, where we asked over 1,800 men who have sex with men, including male sex workers, if they would be interested in this type of approach. Why do we target this population? Because in Mexico, it's a concentrated population where most of the new infections, about 80% of the new infections, are among men who have sex with men. So in this paper, we started with a random number, X, from a feasible range, where we said, if we paid you X amount of money to come back for, say, monthly prevention talks or quarterly STI testing, would you agree to do this? And then if they say yes, we'd say, well, would you do it for 30% less, some sort of bargaining game? If they say no, then we increase the X a little bit. And the machine, the handheld computer, did this automatically. So it was a computer game that they played. It was very discreet. We did it on the streets near the gay bars in Mexico City. It was a great little study.
Did you actually do it? Were you one of the people who was...
I was there. Yeah. I was there, but we had a team. We had a team actually of younger people who were MSM, gay identified themselves, so they had better rapport with them. But I was there a bunch of times. Some of them may not talk to me directly. Maybe I wasn't, good looking enough. But we had a team of trained interviewers who had very good rapport with the target population.
It starts from higher going down or going down up?
It was the initial X was random. That's one of the things. You don't want to start with the same number for everybody, because then you bias it. In psychology, they call anchoring bias. So you don't want to start with the same number. So the initial X is random for everybody, and then the bargaining game starts depending on their results. So if I ask you, would you come for STI quarterly checkups, and you said yes, then we try to make you come for a little bit less. If you said no, we'll try to pay you a little bit money so that you would come. So try to maximize the yes response based on the initial.
The second price was on your choice, not random. The first one was random.
Yes.
But the second one?
The second one was fixed. So it was either 30% down or 50% up. Okay. But so it had that level of randomness because of the first one was jumped.
Sensitive. I think in West Africa, you'll never be able to go down.
Ah, interesting.
You only go up.
Uh-huh. Well, it worked. So I don't have I don't you.
Yeah, you're right.
The seller or the buyer?
Yeah, it's like marketing. It's like in Mexico, it's very common that you bargain. So they definitely got it. Yeah, yeah. So this is just the basic result. I don't have a lot of the game bargaining results. I can send you the paper, but this is the basic result that you would expect, that as the the incentive offer went up, the willingness to accept also went up. And we did various models of this, parametric, non-parametric, on the monthly talks, on the STI testing quarterly. It's the same result, what you would expect. But so let me tell you, that was the initial would the target population be interested in doing that? And so that got published last year. Now we're actually running a small randomized control pilot. And so this is how it looks. We now have funding from the NIH. It's a small R21. And so we have 200 male sex workers from whom we have baseline data. Then we did a very brief prevention workshop, so everybody would be on the same page in terms of what is needed for HIV prevention, though most of them already knew, of course, that, they need to use condoms, they need to reduce number of sex partners, etc. But anyhow, so that everybody would be on the same page, they had this workshop. And then we randomized into 4 groups. The control group that doesn't receive any incentives, regardless of STI status. Medium incentive, which receives 600 pesos if they are free of new curable STIs. In high incentive, that receives 900 pesos if they are free of new curable STIs. So this is at month 6 and at 12 months individually. And we have an unconditional incentive because in the Malawi study that I showed you, one of the results was actually that unconditional money. So remember, the condition in the conditional trial in the Lancet paper in Malawi, it was to stay in school. But they also show that it was unconditional money was also protective. So that's what we also wanted to test, this unconditional incentive, to see if that would be protective. So this is regardless of STI status, they get 600 pesos at 6 months and at 12 months. So we are running this right now, and we are hoping to finalize the 12-month data collection on the minimum number. So it's about 50 participants per arm by August. So hopefully by the end of the year, we'll have some results on this.
Are you doing cost effectiveness as part of it?
We are not doing cost effectiveness for this. We don't have the funds, but I would be happy to hear about possibilities of who might be interested in funding us for that. The NIH was very, the NIH was, as you know, its money is very tight. So an R21 is really small. So even for this, we had to get additional funding from Censida, from the Mexican government, to be able to finish it up.
In your initial study, did you find, like when you were doing the gaming thing, the game bargaining thing, do you find like a threshold wherein beyond which you did not see any increase in sort of like acceptance rates, or was there any sort of like
yeah, sure. There is. So here, you see it flattens and it goes down.
Yeah.
So if you after $8 or $9, you cannot get them over 80%, 78%. It's very difficult to reach certain populations who would just simply say, no, I'm not interested in prevention, I'm not interested in STI testing, whatever the price. So that has implications for programs, of course.
How often do you test for STIs?
In this randomized control pilot, we are testing every 6 months. Yeah.
You could be infected several times.
Yeah.
Yes, you could, but even 6 months, it's difficult to get them to come back. It's a very difficult population. So, I mean, we wanted to do quarterly, but the clinic said impossible.
But how do you know that they're not taking antibiotics before they come to testing?
No, that's fine if they are. You see, we just want them cleared. Yeah. So the other literature is HIV treatment. And as you know, treatment is prevention these days, so HIV treatment is very important. So we did a review of this literature as well, that got published last year as well. And what we found was already 4 randomized controlled trials offering incentives to improve adherence to antiretroviral treatment. The measurement of adherence is through self-reports and these MEMS caps, these electronic caps that you open, and they electronically record whether you've opened the capsules. And of course, there's issues whether I open it, whether I take it, but they've also measured HIV RNA, so you can see that that's more objective. Very little is known about this in low and middle income countries. So that's what the research that we are moving forward in. I will show you what countries we're working on now. And also, we don't know what the mechanisms are. So most of these research, and now there's an additional one. So there were 4 when we published, and now I know that there's 5. So there's a new one from West Haven, from the VA in West Haven. Basically, you pay people to take the pills, they take them. You stop paying them, they stop taking them. So it's strange, and we don't know why this is happening. And this is a very stable result. So we need to think more deeply about the mechanisms, and we're thinking about that.
Even if you take, if this has happened for a long period, they stop anyway.
Yes.
Sometimes they get into the habit of change the behavior is going on for a
Yeah,
while.
I don't have the length of this study. So this is Rigsby, Javankat, Rosen, Sorensen, and there's another one, Ferber, who's not in this study. But some of them were at least a year. And some of them are very big studies. This one has 90, and I believe this one was for at least a year. And so even after a year of doing the incentives, habit formation doesn't seem to be kicking in for some reason.
Are you also looking at TV?
Not on these studies. As far as I know, these studies do not look at TV.
No, I'm just saying it's the same. TV in some ways you have to adhere to a drug.
Oh, yeah. I see.
There are
So,
incentives for TV.
yeah.
Adherence as well. There are other programs that
Yeah.
offer some.
Yeah, I did not find studies that were doing HIV and TV together.
No, just TV, but I think they could inform each other.
Oh, okay. Yeah, I was just doing the review for HIV, but in Ghana we are starting to do HIV and TV, so perhaps I should talk to you about if you know some particular ones. I know from your book, I think I remember there was something. Yeah. So I don't want you to, you probably cannot read, but it says here decreased 1 log 10 and undetectable HIV RNA. So they did see some decreases in HIV RNA, so, which was very interesting in these studies. So just to quickly tell you about the future and ongoing work. So in Mexico, we do want to extend what we are right now. We have incentives to stay free of new curable STIs. We want to do incentives for early treatment. I didn't have time to show you, but we have the baseline data from the male sex workers, and on average they have 5 to 6 sex partners per week, and about 20 to 30% of the HIV positives are not virally suppressed, and HIV positivity is about 40% of our cohort. So we have a lot of HIV positive participants who are not virally suppressed and who are having a lot of unprotected sex. About 20% of the acts are unprotected. So we've done simulations with my colleagues in the Department of Epidemiology at Brown, and we've discovered that the incidence rate is about 8%, so 8 per 100 person years. And of course, if we increase condom use, if we increase HIV treatment, this prevalence could come down substantially, and in theory, all the way to 0. And we have a simulation paper which is under review right now, so I will share that with you hopefully soon. In Kenya, we have a student right now who's finishing up a master's, going into the doctoral program, looking at cash transfers and future outlook and other mental health outcomes on orphan and vulnerable children. So it's an interesting topic for us in Kenya. In South Africa, we've just been, we received Brown University seed funds to look at a small pilot for incentives for dual protection for young women. So contraceptives and HIV prevention. As you know, in South Africa, this is a big issue, a very much of a feminized epidemic. In South Africa, we're working also with a colleague at University of Cape Town at the Department of Economics, and a new project calling it iLink, which is incentives for the first linkage to treatment after diagnosis. So as soon as I come to the HIV test, I realize I'm positive, I'm most likely not to come back. This happens in Mexico, and it happens a lot in South Africa. So what sort of incentive may make me go back to the clinic to start being in regular care and in treatment as soon as possible, because the sooner I am in treatment, the better for my health, but also, of course, for the health of my sex partners. We're also looking at the impact of the government cash transfers on STIs, including HIV and HSV2 in South Africa. We're looking at the data from HPTN 068 in collaboration with Audrey Pettifor at UNC Chapel Hill. So we are excited about that collaboration. And in Ghana, as I told you, I'm going to Ghana in a couple of weeks, and we are starting there also a program with the Adolescents Clinic. We are working with Dr. Anthony Enemel in Kumasi. He has about 2,000 children on treatment and about 200 adolescents. And the problem is that the kids, when they're young, they're taking their pills. But as they hit 11, 12, 13, they don't want to do what mom says. Sometimes they don't know what they're taking the pills, so the issues of disclosures are a big issue. And adherence levels drop. And of course, that's not good. And so we're trying to see what's the best way of perhaps doing some sort of group motivational support with incentives to see if these adherence levels can be maintained. So more of that in the future, and with that, I thank you.
Can I ask you, are any of these looking at cash versus in kind, or they're all doing cash?
So in Ghana, perhaps we will do cash versus in kind, just because they are very young and they may be moved by, I don't know, a lottery where they might win an iPod or something like that.
Okay. Do you want to say something about lottery versus a transfer payment? So that's another
right.
version of this.
So in South Africa, we were going to test lottery versus fixed incentives. So there is a new study by Damien de Wolk and colleagues from Lesotho suggesting that lotteries are also very effective in reducing STIs. And so the idea of lotteries is very interesting. Of course, Nancy Petrie from UConn has demonstrated that lotteries are very effective for drug addictions and smoking cessation, and again, that's the contingency management literature. So the psychologists have at least 5-10 years leg up on the HIV economists. So we know that the lotteries work for other conditions. We don't know whether the lotteries work for HIV yet, so we are working on that.
So, when we start thinking about the implications of these for scale up in a country, of course, I think that the lottery idea is possibly, well, it depends on the application, easier to implement, in that here you're probably, you have to have the resources to test people and, a whole system that you put in place to know who they are and have them register. Whereas with a lottery, you say, you show up, I give you a lottery ticket, and then, one ticket, and because you showed up, that's the ticket you got, and then we pick one out of the hat and we call you, and it reduces the management costs hugely. So I think that that's a big part of the kind of thing we should be looking at.
Yeah, we're very interested in the cost effectiveness, of course. Yes, we will definitely look into that.
And then the other question I had was, have you looked at all at male circumcision? You're interested in prevention.
I have not worked on it directly. I do have a colleague, Harsha Thirumurthy at UNC Chapel Hill, who has been working a lot on this. So he has a KO1 to look at incentives for circumcision. And I think he has 2 trials going right now, one in Kenya and another one in Zimbabwe, I believe. He got money from 3IE.
But the super targetedness of these interventions, in a way, is okay, because we don't, now they think it's much better to be very targeted, but then there's all kinds of ethical implications around targeting versus not targeting, which maybe we'll talk about in a moment. But
yeah, I was wondering, Omar, great presentation, very interesting studies. I'm wondering, in addition to the conditional cash transfers, is there anything else that the participants are provided, like education? I mean, you mentioned in your RCT that there was like a prevention workshop for the MSM. but is there anything else in addition to these cash interventions, and how do you determine what works best?
So everybody receives an inconvenience fee. So everybody receives 100 pesos, which we actually split it into two. So the exchange rate is 12.13, so it's not a lot of money. And so they get 50 pesos for the first visit. So at 6 months, for example, I have to go back, get blood, urine, and I get 50 pesos, regardless of where I am, what arm I am. Then I come back to get my results and to get an incentive if I am in the incentive arms, and that's another 50 pesos. But everybody, even the control group, gets this inconvenience fee of 100 pesos.
So no like education component or no other intervention?
There is a very brief counseling session that may take, between 3 and 5 minutes if it's negative, and between 10 and 15 minutes if I'm positive, because then they have to refer me to, antibiotics or whatever, the STI clinic. And when it's HIV positive, then there's the Mexican guidelines of, STI, basically debriefing and counseling, which can take 15, 20 minutes. And we've had some new positive cases for HIV, even though, at the beginning there were 40% already positive at baseline, but still, because of the high risk, we still have new infections, yeah. Sure.
Also, one quick comment just about the lottery. So the Lesotho program, they're actually still doing the testing, and then you get the lottery ticket only if you test negative for the STIs. But a really interesting comment about that was they were concerned that if people didn't come home with the money, it would disclose to their partner that they had this STI, and they were really concerned about that. But so they had a really interesting workaround with the lottery, was that they would give them the lottery ticket regardless, but they wouldn't put it into the bucket for the drawing. So that way they could come home and say, and show their partner, oh, I did get that.
So what is that? Is that a comparison of lottery versus cash? Is that
No, they're just testing the lottery now, but so in the RESPECT trial in Tanzania, they had done it where it was, you come, you have the result, then we give you the cash transfer and the payment. And in Lesotho, they were very concerned, based on some of the formative research they had done, that it might lead to some intimate partner violence. The women were very concerned that, well, if I don't come home with the money, my partner's going to know. And so that was part of the interesting workaround, even just thinking about mitigating risks, which is a very important ethical consideration, and sort of a very, aside from the scalability and the fact that less cash in the long-term implications for that kind of a program. But it was also just a very interesting way to think about risk mitigation within that
I
structure.
hear you, but there must have been some expectation by the men, or somehow that cash was supposed to come if they're negative, and that came from somewhere, right? To need to have this workaround.
Right. So it was in some of the formative research they did when they were planning. When originally they were just going to transfer the same model, different STIs, but same model from Tanzania to Lesotho, and then they realized that this was a real concern among the population. So they said, okay, we're not going to do a cash transfer. We're going to do it as a lottery. And they also found that people were very excited about the idea of a lottery. That it was a way that
so
community
the
would come
lottery
together.
Was a solution to
Right.
this problem. Got it.
Exactly.
Okay.
In addition to all the other benefits that might be associated with doing a lottery. But just an interesting anecdote aside from just those scalability
Thank you.
thoughts. I will try to do this as quickly as possible so I can leave some time for discussion. But today I'm going to talk a little bit about ethical considerations when you're thinking specifically about which conditionalities you're going to require beneficiaries to do in order to get the payment. So what I'm calling sort of the which strings attached question. And again, there are a number of different kinds of ethical questions you could ask when you're thinking about the design of CCTs, everything from targeting and the eligibility criteria to who's actually going to be the payee, if it's for a household, to whether or not conditional incentives are the right approach in the first place. But assuming that there is a good justification for using the CCT approach, then there's really still this huge question about how program designers should think about what are the right conditionalities to attach, and what sorts of moral considerations should be brought to bear as you're evaluating all of these potential conditionalities that you could attach and require for payment. So this is just a couple examples of the different kinds of conditionalities you could theoretically have. I have them sort of listed across 3 different types of health goals. So the first one, I know it's a little tough to read these slides. The first one is looking at reducing maternal and infant mortality. And you could see everything from having in-facility deliveries to having an attended birth in the home to compliance with taking antenatal vitamins, all the way to actually having a baby with a normal birth weight. And so I sort of have this over here, everything from the distal factors, which could be something as far back as Omar mentioned as education. We know that has protective effects for a whole range of health outcomes, including HIV, to utilization of specific health services that we know will likely influence the outcomes, to more proximal things like medication adherence or vaccination, to actually achieving those outcomes. So, no matter what you're thinking about, whether it's reducing HIV incidence or trying to improve childhood nutrition, growth, and development, there's a whole number of things that you might consider. And the question becomes, how do you sort through it and figure out which ones you're actually going to require in your program? And to put this quickly in context to some of the work that I'm doing, what I'm going to present on today is sort of just the very preliminary conceptual work about what is actually morally relevant, what from an ethics lens should we be thinking about when looking at these different conditionalities. But I'm also doing ongoing work on the empirical side, where I'm actually meeting with various program designers who have gone through this, or either in the design phases or have long since finished implementation, to get their experiences, find out what their rationale was in choosing the design approach that they did, maybe some of the unexpected positive or negative things that they saw in implementation. And that's been really valuable and interesting to hear about those experiences. And then combined, I'm going to use sort of the conceptual basis that I'll talk a little bit more about today with the empirical findings to try and develop a step-by-step guidance document that will help people who are actually working through these program designs to think systematically about the ethics of choosing their conditionalities. So I welcome your feedback at any point. This is a work in progress, but that's sort of the end goal, and I hope to share more of this work with you as I move forward. So I promised I would talk a little bit about what these morally relevant considerations are. So far, I've identified 8 categories of morally relevant considerations. So the first one is looking generally about effectiveness and the likelihood that whatever conditionality you require will actually yield the desired outcomes. And so I've divided this up into 3 different dimensions. The first is that, what is the evidence that supports that there is actually a causal linkage? For most of these things, we have a general sense of, okay, is there an evidence base that if we require people to get vaccinated, that will actually reduce their incidence of whatever disease that vaccine protects against? And for any of these kinds of interventions, generally we would want there to be a pretty solid evidence base, at least establishing that causal linkage before we ask people to do something. In addition to knowing that there is a causal linkage, looking at the expected magnitude of that benefit. Obviously from an ethics perspective, we always want to try and get as much benefit as possible. And thinking about things within HIV prevention, we could look at everything from, using microbicide gels to circumcision, somebody mentioned, to medication adherence, and we know sort of ranging from 30% to 90% protective effect from microbicides to treatment as prevention or PrEP. That's a pretty big difference in terms of magnitude. So that's also morally relevant when we're thinking about trying to maximize the associated benefits.
Can I ask you a question? Do you consider community benefit as well as individual benefit? I mean, you gave a vaccination example. So in fact, vaccination is not useful for most people.
Right. I will get there. Give me 2 more slides. So yes, this is at the individual level benefit. And then there's also this question about durability or permanence of effect, which Omar had raised in his consideration, even looking at treatment adherence, that what happens when the money goes away, maybe you don't see that permanence or that durability of the effect, whereas something that, circumcision, once you're circumcised for life. You don't have to worry so much, that's forever. So these are all really important considerations, and they're things that should be taken into account both in the planning phases and also to the extent that there are sort of unknowns, you should be building that into your M&E plan so that you're monitoring and seeing that those outcomes are actually realized and realized to the degree that you believe them to be. So the second one is this idea about receptivity. How receptive are the intended beneficiaries to whatever you're proposing they have to do? And this obviously will be across the spectrum. Some people might be very receptive or very welcome to what you're offering and say, oh, I've always wanted to, in the case of exercise, go to the gym. I just didn't have the motivation, or, it was too costly for me to get there. But now with the the new CCT, I'll have this extra money, and so now I can do that. And you see that a lot with health utilization, that a lot of times beneficiaries do want to do these things. There's just been some sort of barrier. And in those cases, it's not very problematic at all. That's sort of great. People always sort of raise this question about, oh, well, aren't CCTs going against people's autonomy? But in this case, it's really autonomy promoting. But it's important to understand whether or not they are receptive to that. On the flip side, you might have behaviors that might be unwelcome to people, where they're really resistant to whatever you're proposing. And that's where you start to get into questions about, is this constituting some sort of a threat to individual autonomy? Is there a possibility there might be an undue inducement by providing this money and this external reward that would make them do something that either seems against their best interests or really makes them compromise their values or something that's intrinsic to their sense of self? In order to assess that, you not only need to look at whether or not they're receptive, but in cases where there's sort of this low receptivity or where people are really unwelcome to whatever you're offering, looking at what those sources are. So is it purely just that they're not informed about what this behavior does, or they misunderstand what's being asked of them? There was a case in Turkey where people were being asked to get vaccinated, and they thought that this was a government program to sterilize them. So clearly those are the kinds of things that can be easily addressed with the right kind of legwork to do the proper community engagement and education activities in advance to make sure that there is adequate information and adequate understanding, which, you know, when you're doing any program is sort of an ethical requirement regardless, just out of respect to the participants. But especially in these cases, it's really important in terms of increasing receptivity. Then you start to get into some things like these deep-seated values. And that's where you really have to be concerned about threats to autonomy, where it's something that somebody really cares about. It's important to who they believe themselves to be. And if you're offering them a lot of money, you know, most of these programs are targeted at people who are very destitute, and it might cause them to go against what their best judgments are, and that's where you start to have these ethical concerns. It's important not only at the individual level to look at receptivity, but also to look at the household and community level. And this has both sort of the instrumental value of, you know, if people are more receptive both at the community level and household level, they're more likely to practice behavior, you're more likely to see the outcomes. It's also important to think about what kinds of risks might be associated, which I'll talk about shortly. But again, if people in the community are not really accepting of whatever behavior you're asking them to do, you might actually be putting them in harm's way, which is something that you always want to try and avoid. And so understanding receptivity does come with some sort of practical implications to do some legwork, to do this sort of formative research and community engagement with the beneficiaries in advance to better understand this. And then this sort of list of all else being equal, you know, you should favor the conditionalities to which the beneficiaries are receptive over ones that are quote unquote unwelcome. So the third consideration is how attainable these conditionalities are. You know, is there a reasonable opportunity for the beneficiaries to actually comply with what you're asking them to do? And this also has a lot of equity considerations, particularly if there's subgroups of people that just, they're not going to be able to do it. There's a lot of, you know, for the healthcare utilization, communities that are very remote versus people that are very close to the health post, you know, there's a very unfair advantage of being very close, and then you're sort of leaving those who are the worst off, who are already far from the health post, in a worst case scenario, because now not only are they not getting the health services they need, but they're also losing out on this opportunity to benefit from the cash transfer. So that's really important, and it raises questions about what kinds of ancillary or complementary services should also be offered to try and have this reasonable opportunity for the attainment of the conditionalities. And there are some interesting examples where sometimes even the number of conditionalities that you offer, you'll say, okay, we need you to do at least one of these three things to be able to get the conditionality. So in Tanzania, they added a new conditionality for one of the programs that they're currently scaling up that has these health workshop days where they have, you know, a mobile team that goes out and does a day. And so that way, instead of having the normal compliance with going to a health facility every 6 months for the children, that they can participate in these health workshops as their opportunity to be able to benefit because they're just too far from the clinics. So those are all really important considerations. So you asked a moment ago about some of these indirect benefits and the positive externalities and the societal benefits. You know, when you're thinking about the balance of whatever the risks and the burdens are versus the benefits, it's not just to the individual, it's also really important to look at what kinds of other benefits are associated beyond just that particular targeted outcome you're looking for. So these could be indirect benefits to the individual, that, you know, the fact that they are healthier means that they have higher attendance at school, in the case of kids' health. It can be some of the spillover effects that you might see for other children if the women become more health literate and they're learning all about nutrition, that, you know, it's not just for those under 2 or under 5s, that all of the household may benefit. So there might be some of those to diffusion of knowledge across, you know, households that aren't even participating in the program, but, you know, the norms shift and all of a sudden this is the new thing to do and everybody's doing it even if they're not getting the cash. And then there are obviously things like societal benefits in terms of having a more productive workforce for people being healthier, infectious disease control in the case of vaccines. And as many of you know, a lot of these programs do have this sort of women's empowerment component to them. So there's all of these sorts of externalities and benefits beyond the individual. So on the flip side, we talked a lot about benefits. But it's also really important to look at what sorts of associated risks and burdens there are. So this is not just the physical risks, which are sort of how we typically think about in bioethics, you know, risks versus burdens, but also what kinds of social or psychological risks there might be. So you could imagine something that looks at collecting your STI or HIV test results. There clearly are some psychological risks, making sure that you mitigate for those risks, have appropriate counseling in place, give them enough time to digest and then link them to care. And also the potential for social risks, you know, the fact that they might be identified as being HIV positive if they're still in a stigmatized community, that could be very harmful to them. And similarly, you have to look at the level of the household. Again, in places where it might not be a very well-received type of behavior or where there might be certain religious norms, if a household is seen to be participating in this program and it's incentivizing something that might hurt their sort of social standing in the community, that's something that's also important to consider. And then going beyond sort of the individual and the household to looking at some of these larger negative externalities, you know, what kinds of impacts might there be on non-participants? Are resources going to be diverted away from other people in the community that aren't part of that program, and what kinds of impacts that might have? Of course, thinking about the supply side, I think everybody here probably knows if you're going to do a demand creation strategy, you need to make sure that the supply side is in place to meet that new demand, and, you know, this is really crucial. But I've actually been seeing, I mean, there's a lot of pairing of supply side and demand side incentives as well as supply side investment. So that's at least, it's good to see that that's being taken into account in most places. Other things to consider are the potential distortion of local markets. So if you're doing something like a nutrition program and you decide, okay, well, we want to actually provide these nutritional food sources, then how might that affect local food vendors? You really don't want to create a situation where you take away the livelihood in the community or really disrupt the local markets with this kind of a program. And then again, just thinking about any kinds of social structures, you know, in places where social capital can be one of the biggest assets that a lot of these families have, it's really important to make sure that you're not creating some sort of a new pattern that really breaks down some sort of the community fabric and the social value of certain interactions that are quite valuable in that setting. So number 7 is the potential for unintended consequences, and this one's tricky because, you know, unlike these other ones, which are generally pretty foreseeable and you can do a lot of work in advance to try and understand, this is sort of the, okay, well, how might this backfire? And it's pretty hypothetical. But the idea is that, you know, to the extent that you can sort of brainstorm as much using the existing theory, what the potential is for certain unintended consequences, and then put the mechanisms in place for monitoring and for feedback so that you can capture the emergence of these negative unforeseen impacts. It's really important. It might even to the extent that if you theorize there might be potential for a lot of it, you just don't know, then maybe you start with a smaller scale pilot so that at least you can minimize the amount of potential unintended consequences that happen before you have this larger program at scale. This also requires a little bit of thought about what your eligibility and graduation criteria are, as well as payment size. You know, if you had something where you were trying to help infant and maternal mortality rates, and let's say you had to have a child that was, 1 year old, you might actually increase fertility and then reduce birth spacing, and you might end up having some sort of negative outcome that undermines the entire goal of the program, which is obviously something that you would want to avoid. So all of these are important considerations. And then this last one is this potential effect on intrinsic motivation. So there's been a lot of talk, and there's a big study about this idea of motivational crowd out, that if you introduce an external reward, that whatever sort of intrinsic motivation people had before you introduce that external reward will sort of be eroded or washed away. And
did you say there's a study about this?
Yeah, so Bruno Frey has done some experiments with it. I haven't seen very much literature in the CCT world. There's one study right now that's looking at like washout effects over the year and a half following the program in South Africa. So it'll be interesting to see what they find. They're not there yet. But there's very few that are really looking at these sort of longer term, what happens to intrinsic motivation. And it's also a little bit hard to capture.
It comes up, and there are issues around what happens when you stop.
Mm-hmm.
And I think the question is, do people go back to where they were before, or do they actually get worse?
Get worse, right.
Or has their behavior changed, permanently in some way? And there's sort of, everyone brings it up.
There's not very good data, no, and there should be. There should be more long-term follow-up, because there's been a lot of pilots, and I think the longest-term follow-up I've seen is 18 months, which isn't really necessarily long enough to see how far out and if they actually get worse off than they were before. Anecdotally, I heard a story about, it was one of the programs with adolescent girls staying in school, and they actually got worse, but it was they had become one of the main earners in their family because of their participation in this program, and then when they dropped out, they were compensating to try and make up to maintain that role as one of the key earners in their family, so they were engaging in transactional sex, which is, it's not exactly the same as the crowd out, but it's a negative unintended consequence. And crowd out is more concerning in some instances than another. I mean, on the one hand, if it's vaccination and you get your 3 doses, who cares if you're crowded out? You're protected. So this definitely relates to sort of that durability of effect, versus if it's HIV medication adherence. If you crowd out, I mean, maybe it's neutral. Maybe they didn't have any motivation beforehand. We introduce the money, they have no motivation again. But if it's worse, and particularly when you're thinking about resistance, and I mean, there's a lot of really important considerations tied to whether or not the crowd out phenomenon is actually happening. Then again, you could also see crowd in. I mean, there's a lot of people that say, okay, yeah, the habituation type of comment of once we get people to see the value and see that there is a health benefit associated with doing this, that they'll continue to do this even after the money is gone. So that's sort of the sweet spot. If we can get that crowd in, I mean, that would be, the public health dream. And then it would continue to sustain long after the intervention is gone or after they graduate out. So I think it's important to try and look for this, but it's also, thinking really carefully about what is the health problem you're trying to address, what behavior might you be crowding in or crowding out, and thinking about that. But it is tough in the context of very little data on how much this is more of a theorized phenomenon versus an actual one. I mean, the best evidence I've seen is from the education world, where it's, crowding out motivation to read. And maybe these also have, bigger effects on children who don't have these sort of form. They're more malleable in their preferences and in their motivations. But yeah, and it's also tied to sort of that baseline receptivity. The potential for crowding in where there's low or neutral receptivity is much higher, and potential for crowding out if there's high receptivity is also higher. One thing about, if there is really high receptivity, it may be shown that you don't actually need these conditionalities. If you just give them the money, if they really want to do it, they're already motivated to do it, then why are you attaching conditionalities in the first place? And from the economic standpoint, it's certainly more it's more efficient to not have conditionalities. You get rid of all the administrative costs. So that was a whirlwind presentation. I think we're a little bit over time, so I have a couple other sort of instrumentally relevant considerations in terms of how much it aligns with the programmatic goals. Again, I mentioned sort of the structure, number, flexibility, complexity of the conditionalities, depending, if there's a few that people can try and comply with, it makes it easier for them. It also makes it easier for them to say no to the ones that they don't necessarily want to partake in. If there's a receptivity question, as Omar mentioned, how measurable what you're looking at. You don't want people gaming the system, or you don't want to be rewarding people who actually aren't complying. Yeah, so there's a lot to think about in this space, and I wish I had more time to talk through this with you, but I'll open up the floor now.
So, yes, what about, for example, in oportunidades in Mexico, where there's lots of good things happening, but there's also some evidence that BMI is increasing and hypertension is increasing?
Yeah, I mean, I think it's really tricky because you want to, if you're thinking about, for instance, a nutrition / you want growth. BMI, I think, as an indicator is problematic for a number of reasons, especially as children sort of do their little growth spurts. But again, I mean, you don't want to be incentivizing weight gain and then you're seeing obesity. And the weight gain is coming from sugar-sweetened beverages, and it's coming from all sorts of things that are actually not very nutritive. So maybe it's just it's thinking about those unintended consequences, and it's trying to structure the program in a way that will support. I mean, I don't know, maybe you have vouchers in addition to the cash transfer that are for purchasing, in the same way that we have WIC in this country that is only for very specific types of food items. I mean, maybe that's the solution. But I think there are some creative workarounds, and this is just sort of the initial challenge to say, you really have to think about these things and not just say, oh, great, okay, we're seeing weight gain or we're seeing BMI.
I think you're going to need to set up one, how Lucy in Peanuts has that little stop where people can come and ask the psychologist a question, because it's an area that really has received so little attention in the literature.
Yeah.
All of these issues are discussed, but not really from that perspective.
Yeah. One thing that I think has been really interesting that a lot of programmers have talked about is the collaboration with experts in their field. So, if you're a behavioral economist, then you want to work with somebody who really knows the world of HIV if you're going to be designing this. And having people who are both, the quantitative and the quantitative people, the qualitative, having people who are really content experts, collaborating on this, because this really is a very interdisciplinary approach, and if you only understand one piece of it, you're much more likely to fall into these sort of snafus or backfires than if you really bring in the right kind of content expertise.
So I think, but I also want to recognize the formative research that you did, looking at, would it be acceptable? That's also very rare. Nobody does that I know, even the cool lottery studies. Rena.
So just, I don't know if you've looked in the family planning literature, but there's a lot of discussion about ethics and incentives in family planning, as well as guidance work that we've done around what is okay and what is not. And there are also laws that we have in this country about how U.S. money can be used to support family planning in other countries. Or not used, yes. So that's, I don't know if you know about it, that's worth looking at. I wanted to kind of respond to a comment that you made.
Sure.
About, if people want to do something, you don't need to give them incentives, and say that that's really actually not true, because all of us make New Year's resolutions and all of us want to lose weight, exercise more, blah, blah, blah. But there's something that happens between when we say we want to and, time later, and that I think some of the stuff from behavioral economics is quite interesting to try to think about how do we put in place a system that makes people do what it is they want to do,
right,
and sort of holds us accountable. And in a way, I think some of these cash transfer programs somewhat are doing that.
Right.
I mean, they're sort of keeping, you know, putting in a system for accountability. So just
Yeah. No. Well, that point is well taken. I think
yeah.
just to address it, I probably was thinking more along the lines of where it's purely an economic barrier, where people say I want to do this, but it's the money, where it's not sort of that motivational piece, which is very often one of the key drivers of why we're not practicing certain behaviors. But if it's purely just the economic barrier, then that might be an instance.
Well, I mean, even an economic barrier is an incentive. I mean, it's fuzzy there, but yeah.
Right.
Alicia, I wanted to acknowledge your work on changing social norms and wondered if you want to say anything about that, because it's quite interesting.
Well, so there was this there's a small project that we did with Rena's group in Bangladesh last year, and it was looking. UNICEF was implementing a variety of activities to try to change activities to delay early marriage. So then they had conditional cash transfers to adolescent girls, and to help them to not get married so early. And what they were doing, and maybe that's what I was thinking about asking about, what else are you doing besides the cash transfer, is they had, in addition to that, they had many other educational activities and both targeted at individuals and at groups to try to develop, I guess, this community where girls feel more empowered. Then they also are tackling the financial barriers. So they were approaching it from looking at all the barriers that there are to eliminating micromarriage, and and then to what extent can those be addressed by financial barriers, by financial incentives versus other incentives. So that's a little bit about that work, and I think in addition to changing incentives, what is expected in the community is also an important point. I don't know if it's addressed so much.
Yeah. Well, there not so much at the community level, but certainly in terms of building other capacity. There's a program in South Africa, the REVA program, where it's incentivizing adolescent girls to stay enrolled in school, to get a yearly HIV test, but then they also have this extracurricular program that has them come up with these strategic visions and gives them job skills training. So it is trying to address some of those aspects, because one of the biggest drivers that they found about why these girls were getting pregnant earlier and having transactional sex is that they had no vision for their long-term future and potential, and that addressing that piece was sort of the most important reason why they would say, oh, I should actually protect myself because I do have a future that's worthwhile to protect. So there's at least a few that are thinking more broadly like that.
You mentioned. Introduce yourself.
Oh, sorry. I'm Karishma. I work at Apt Associates. So you mentioned the programs that link demand and supply side incentives. I was wondering if you could give some examples of some that have worked very well or not, that haven't worked so well, and what were the factors? Because you often see them kind of by themselves, but not often together. So could you talk a little bit about this?
Yeah, I'm not sure I know
Ferdinando should have been here. I mean, Nicaragua is sort of the best documented case of incentives and strengthening on the supply side combined with the cash transfer
and voucher
program.
programs.
And voucher programs.
There are a few programs that are adding on.
But what
Well,
they
even,
didn't do is stress which
JSY
one is more important, or in case you're wondering about that. But we were just talking about a study from Brazil that compares Bolsa Familia to the Sistema Único de SUS versus the conditional cash transfer, and which made the biggest difference for infant mortality. That's not a program that's implemented together, but it's important because both of them they're supposed to be incentivizing utilization. One uses a supply side approach and the other uses a demand side approach. And they find both are important. I'm sure you're supposed to hear that. And Omar is going to do a paper on Mexico. but there's I don't know if you know of other studies in this space that pair supply and demand.
JSY is both, right? The Indian Safe Delivery Program, doesn't it provide both incentives for providers as well as it's also community health workers.
And we did one in Uganda that was combined supply and demand voucher program, but we didn't test them separately. It was just a combined program. successful.
There was just the Nicaragua paper from, I don't know, 10 years ago with the vouchers where the money followed the client. So then you, I think, incentivized also male sex workers, female sex workers. And so I think it was a matter also of providing discrimination-free and stigma-free services that were high quality. So if I was a sex worker, I would go to the place where they treat me better, and then they would cash the voucher. So I thought that was very interesting. Where it was a mix, right? So it's the demand because I receive the voucher if I'm a sex worker, but then I go to the best clinic according to my preferences, and so it's also an incentive for the supply side to provide good service. So I thought that was good. I remember that from 10 years ago at least. That paper.
Go ahead.
David Peters from Hopkins. So I had a question on the ethics of, or whether it's come up in questions on ethics on situations that are not fully voluntary. I'm thinking, for example, of some of the cases where, by court order, you might be assigned to a contingency management program for substance abuse, or as a condition of parole or whatever. You can think maybe on the extremes during the emergency of India for family planning, where they literally round people up off the streets and then sterilize them and give them some money. But that one seems a little bit more straightforward. But in terms of these, the question of voluntariness of participation, is that coming up at all in terms of any of the public policy considerations?
Admittedly, I haven't really looked at the one where there was any sort of court-ordered contingency management type work. Most of these, the voluntariness question comes more from the question of undue inducement as opposed to coercion. So people aren't being forced into these. It's sort of like, is the money so attractive that they would set aside all these other considerations and do it for the money? But
we can't even enroll our kids in school without proof of that they're vaccinated. It's sort of a conditionality, right?
And potentially maybe
Pretty
there's,
strong.
Well, if you want my kids to at the same school.
Yeah.
Right. And there's the social.
Yeah, and potentially there's maybe like some appeals process to opt
Sure.
out. I mean,
I think people can opt out.
yeah, in the vaccination example, absolutely, yeah. It's a little cumbersome, but
my name is Lawrence. I'm from Brown School of Public Health, and I just had a question. So, going back to economic theory and about health being an uncertain good, and how do you, factor in this concept of uncertainty in healthcare and in health, and targeted conditional incentives versus the ethics that underlie, the ethics. Any thoughts about this concept of health being uncertain, and we have all these ethical considerations versus all these targeted conditional transfers?
Well, it's a tough question, right? Because in health, nothing is for sure. So I can try to protect myself, but also there's the question of the economics that wasn't brought into the arena here because I didn't have enough time. But in the baseline data for our cohort of male sex workers, we find that there's about 40% higher payment for unprotected sex. So this is work that has been conducted in Mexico with female sex workers before, and they found 23 to 25% higher payments. Manisha Shah, Gertler, Bertossi paper. And now we have a paper under review showing 40% among male sex workers. So, if I'm in a situation where I may be homeless or maybe I have issues with alcohol or drugs and where I don't know where my dinner is coming from, the market inducement is pretty strong. And so I take my chances, and I know that it's uncertain. I may or may not catch something. And, I hope I don't catch something if I am going to be rewarded, but, that's sort of uncertain, whereas the 40% additional is certain, and I need the money. So it's a tough choice when I have to make these decisions.
yeah. I mean, I think part of what Omar's getting at too is the core idea behind CCTs and contingency management is pulling up this. People discount the future benefits, but if there's something that's very immediate, that they can say, okay, I can forgo this, 40%, but I guess it depends sort of on the structure of the program and how soon you'll get that money. But if it is relatively immediate, then you can say I can forgo this risk premium, because I know it's going to come to me in another way that also is protective of my health. So it helps sort of change that calculus in terms of what's worthwhile. But it is tricky with health being sort of uncertain, and even when you look at the expected benefit, depending, it's really tough with some of these distal things. Education, we generally know it's good for health, but to what extent that's part of the equation that ultimately is leading to X health outcome, it's a bit nebulous. And I've seen a lot of programs that are starting to combine having some payment for actually achieving the outcome, some payment for all of these sort of steps that would lead to that outcome. So that's always a possibility in terms of how you're thinking about it. But you also don't want to have so many conditionalities that it's too complex that administratively it's too burdensome and it's too confusing for the beneficiary. So striking that balance is really tricky.
Can I ask you a question, Omar, about, for example, the sizing of the transfer? So what if instead of having these guys getting only their $10, would you instead say, okay, I'm going to put you into oportunidades, right? I'm going to give you $20 a month, just like a household, because you're a vulnerable group. Would that, is anyone testing that sort of thing, sort of the side, like more of like a welfare approach instead of, we're paying to change the specific behavior approach? Or combine them somehow, I don't know. Or it's too expensive.
Well, in Mexico it has been sort of the reverse, right? When we got to Mexico, I went there in 2006 and stayed there 4 years at the Mexican School of Public Health. So our approach was, how do we target oportunidades to people that are highly vulnerable for HIV? And quickly we realized that we need to work with men who have sex with men, and in particular with male sex workers, because now we knew that that's where most of the new infections were coming from. And our cohort is certainly very representative of what's happening in the rest of the cities. We now have data from the country as a whole that my colleagues at the Institute have recently collected. So the issue of politics is interesting, right? Because these highly vulnerable populations are perhaps not very politically connected or not very powerful constituencies. And so the politicians are not, running to the door to take pictures with these highly vulnerable populations. So I think the Ministry of Health and Censida are very interested to do this type of work, but I think one has to do it carefully and step by step, and showing in each step of the way that it's beneficial, and hopefully that there'll be an effect for society as a whole.
The closest thing that I've seen to sort of adjusting based on need is where the compensation is dependent on the size of the family, and we'll take into consideration all these different things and adjust within the range. But I haven't seen anything that sort of does this differential, which is sort of an interesting question.
Yeah, and I'm just thinking, if you look at like Zamba and some of these other kinds of trials, they're just giving cash to teenage girls, conditional, and many of them are unconditional programs now, and they have big effects on HSB and HIV without any conditions.
Yeah.
And that's with, a group of adolescent girls, but you can imagine maybe, with an Amazon that's engaged in high-risk sex a lot of the time, with this 40% premium, maybe it would just change the calculus so much more than, would we only care about them coming back to check for STDs, or do we want, could we have a bigger effect on their behavior through this other mechanism? Yeah. That's the only question.
The Tanzanian program, the TASAF program, does have an unconditional component because everybody that is within their target range is also qualified for this social cash grant, and I think that there's something similar in South Africa, the child support grant. So a lot of those girls are covered with that unconditional support, at least up until a certain age. But yeah, I think that the combination of having some sort of unconditional transfer along with the conditions.
We just had this event on Friday that was basically a big jamboree around Give Directly, which is all unconditional grants. But the idea there was anytime that we propose, whether it's a conditional cash transfer grant or an in-kind or anything else on the supply side for real long, that we should be comparing it to an unconditional cash transfer in terms of its efficiency and its impact, and maybe ethical considerations as well. So, yeah.
So I've been struggling, I guess, Carleigh, with trying to think through what are the sort of practical implications of what you're saying. So I know that you're trying to produce some kind of guide or tool that will allow people designing conditional cash transfers to think through the sort of ethical issues involved. And it seems to me that some of the ethical dilemmas that you set up, you could set up a sort of fairly straightforward guide which would help people think about it. But it all seems also that there's always going to be a set of effects which are unpredictable, difficult to know about, and I was sort of thinking, well, how big are they? How significant is that bundle of effects? And what can you do to address those as opposed to sort of more straightforward things that you started out talking about? And I guess, you know, any health program has often unexpected consequences, and typically you would say, well, monitor, evaluate, change course, that's the thing to do. But I wonder for CCTs if one of the challenges is that once you've communicated your conditions, you can't keep changing it and adapting it because you're going to totally confuse the populations that you're talking to. So that seems something to me which makes it, the program perhaps a little bit different to a sort of regular health program and the unexpected risks that are likely to arise in any of those. And then the other thing that was sort of going through my mind is, well, besides, say, a guide to the ethical dimensions of this, are there other things that the global community should be doing to try and support more informed decision-making about conditional cash transfer design and in particular sort of moral aspects? And besides do your formative research, which seems like a really good thing to do in any case. I mean, I wondered to what extent we were sharing information, we were sharing the right kind of information about the consequences of CCTs. And, you know, in journal publishing, we're always pushed to get everything down to like 4,000 words, and often you focus on the primary, you know, your research question is, did it have this impact? And you report that, but you may not report half a dozen other things that also happened and that were really interesting and really important from a moral or from health consequences. So I wondered if you had any more reflections on the sort of the broader institutional implications of what you're saying. Like, should we be putting in place things to help share information in a different way? Should there be some kind of ethical review of these CCTs before they go to the field? And I'm addressing it to you, but there might be others who've also got good ideas.
Yeah, and I would love to see various procedural mechanisms in place that would ensure that, the same way that if you have a research protocol, it goes to an IRB and there's some sort of systematic review of the design, and a lot of different heads kind of coming together and raising concerns that you might not have thought of yourself. So it would be great to see something, even from the development banks, if they had, some sort of processes in place to read that. And that's sort of for any of the work that's being done, not just CCT, but also to the extent that there were, better knowledge sharing platforms. Because you're right, journals are very limited in what you can actually put out there, and the gray literature is, sometimes tough to sort through. There are some resources on the web, and to the extent that people are seeking technical assistance from the development banks who do have expertise in this area, and I know the Tensium program sent 2 of their staff members to do sort of quick residencies in Brazil and in other areas where they had already gone through the process to sort of better understand what's going on. So there is some collaboration happening, but to the extent that we can foster more of that, I think it would be really great.
I think one thing that's very true about, first there's a lot of qualitative evaluations alongside the impact evaluations, and they're out there. Maybe they're not as frequently published. Most of them are in the gray literature, and certainly Oportunidades has n number of things. They're all in Spanish on the Oportunidades website, but it's there. And I guess I think all of these things should ideally be in the country rather than as a filter at the banks, just because, I don't feel like the gender and indigenous people safeguards work very well to change, it's very tough. Instead I think a consultative service would work better, But I also wanted to go back to this issue, the unconditional cash transfer programs that are so popular now. In Africa, they don't like to talk about conditional cash transfer programs. There's this discourse around a minimum level of income is what is entitled. This is a right. This is not a discussion about, why should we condition this for people to just attain a basic standard of living. And so they prefer to call them social cash transfers. And maybe that will happen elsewhere. Maybe we figure out that the conditions are actually inefficient, right? That we can change people's behavior just by moving people up to something.
So maybe put on some hospitals that this also sort of gets at, the the debate about like different social values and cultural norms across, and so not being able to kind of like do this with a broad brush. I mean, your idea of like having a consultative service of kind of like have a booth that it's sitting at. And
it's the New York Times.
Yeah.
If anybody wants to fund that, I'm available starting in March.
But also around kind of like these neighborless areas of deep-seated values, where individuals are sort of like beyond they are at a level where sometimes the programs, the top-down nature of the programs themselves, even with the formative research that you may have, or even with the with in-country collaboration with people who are thinking about social values, sometimes the indigenous perspective, or the native perspective, or the beneficiary perspective may not sort of like be the primary perspective that's being addressed. So while we may talk about all this, kind of like the practicality and kind of like the realization of it on ground continues to be like tricky, and sort of like having a list down or kind of like a checklist is helpful. It's a good starting point, but then I think there need to be like many more practices sitting and doing this programmatically at each sort of like each level of implementation.
Well, Luis from Johns Hopkins also. In these ethical things, and you talked a little bit about the coding out or unintended consequences, but so for example, I think in opportunities, they're thinking now what happens when the people is not eligible for the program anymore, right? Like they're not dropping out, or they're just dropping out, they're just simply not eligible anymore. And in opportunities, I think they have found that people, the money they receive, they see it as a certain income. So when they stop being eligible, they don't have that income to delay. Like, what happens next? Like exit doors.
I mean, graduation and eligibility are really important questions. I'm not addressing them in my dissertation. I mean, it's a huge space to cover, but it's really important to think about what happens after they're out and what sorts of transitions you might have, or thinking about appropriate sort of ways to get them instead of just saying, okay, you're no longer eligible, go on. And because the idea is that you still want them to have a certain level of well-being and health. It's not that you stop caring about them as soon as they're no longer eligible.
I kind of always thought that the exit strategy should be a generational exit strategy, right? Because the whole idea of these programs, right, was that you were investing in the next generation, and that it's the next generation that exits the program, not the parents, because the parents are not increasing their skills, basically, right? But that said, I mean, they do recertification every 5 years. I don't think they found huge effects on jobs, labor market participation, and things like that. But it was more, they lost a lot of their sample because many people migrated, and actually that's probably a good outcome. So maybe I think these papers are understating what the effect is on the openness, on people who leave the program. I don't know what you think, Omar. It's quite politicized, this discussion of graduation, and these people. There's a lot of people.
Do we know that a lot of the people who migrate were
they lost half their sample to migration, and they followed up most of the people. Was better than I did, but most people in the country they found again, but lots of them went to the United States, and now they're actually finding those people who migrated to the United States and understand what they're doing as people.
That's interesting.
Yeah, it is hard to get at some of these outcomes because the experiment was also so long ago. So, I mean, you have a short experiment, which I think is 18 months difference between 1997 and 1998, which was the cluster randomization. And so then the effect is, what is the effect of having been exposed to this 10, 15 years ago and this difference? And so that's what they call, the long-term effect. And if you lose a lot of the sample because of attrition, it's really hard. And then once, for some outcomes, we've done the analysis, and if it's differential attrition, so you're in a really tough spot. And then you have to start doing very fancy inverse probability weighting and other corrections to account for that differential attrition. And then the papers get very complex, and then they take longer for them to be accepted. Speaking for a personal experience. So we'd love to know everything about what happens, but it's just hard. because these experiments were not designed to answer those questions. And so you have to become very creative with these new methods and come up with instrumental variables or something, and it's hard. So I don't know if we know the answer to those questions. Very good questions, but it's hard to know the answer.
There's the Nicaragua program that was actually stopped after some period of time when the new president came. They've actually followed the migrant. They found the migrants. They found like 90% of their sample. Crazy, crazy. And there's finding effects on learning, for example, and on labor productivity. So maybe it's the case that we lost so many of the ones in the communities. We just don't know what happened. But who knows? Hopeful, hopeful. All right, well, I think we've reached 1:30, and so thanks to you, for coming.
So Sarah, why do you think